Good afternoon. Thank you very much for joining us at the Stanford's Maternal and Child Health Research Institute monthly seminar series. I'm Tony Oro, one of the co-directors for the MCHRI. And today we have an amazingly talented program to present to you. Really a model of global health studies led by Gary Darmstadt, who's a associate professor, a professor of pediatrics here at Stanford. And then an all-star cast, which will be introduced as we go along, really focusing on lessons from maternal and child health studies in India. And so before we get to that, just wanted to provide some sort of bookkeeping issues. Really the first is in the same theme, this year's Maternal and Child Health Research Institute Symposium. Please book in your day timer for this, which is Thursday, October 28th, headlined by Kelly Moley, who's the Deputy Director of Reproductive Health Technologies at the Gates Foundation, really focusing on global priorities in reproductive health technologies, as well as three other keynote sessions around emerging topics in maternal and child health. So Thursday, October 28th, there'll be a call for abstracts and very interactive type of symposium to really highlight what's going on here at the Institute. Next slide. After this session, you'll be getting an online survey. We'd love it if you'd actually give us some feedback about the things that you like and dislike, suggestions, and other topics that you'd like to see. We really take these surveys very seriously, and so please help us with your opinions. And today, really, I don't want to give take any more time from this amazing team, but really, today's seminar is led by Gary Darmstadt, learning from piloting in statewide scale over the last pretty much 12 years of the Ananya Maternal and Child Health Program in Bihar, India. And so, Gary, I'll let you start. And but really, this is an amazing model for us and how to model maternal and child health across the world. So Gary, thank you very much for joining us, the team. We look forward to this wonderful seminar.
Great, Tony, thank you so much. We really greatly appreciate the opportunity to be with you. And thank you to Roxana for helping us pull all this together. So let me go ahead and share my screen here. Okay, can you see that? Is it?
Yes.
Yes.
Okay, great. All right, as Tony said, we're going to be talking with you about a very large-scale maternal and child health program that's been going on in the state of Bihar, statewide, in India. You can see here on this slide, this is a very large group of collaborators that cuts across several NGOs, academic partners, and in partnership with the government. Those of us who are going to be presenting are shown at the top. Stanford contributors are in red, and the rest of our partners are shown otherwise. And here we see our collaborative partners all coming around here, the government of Bihar. We had a collection, again, of academic and NGO partners. And Stanford was in charge of pulling together this learning. This came about in part because I had been at the Gates Foundation when this program was conceived and developed, and was in large part funded out of my team. And then when I came to Stanford, the Gates Foundation, who funded this program, asked me to help to capture this learning. So it was our job to pull together understanding around the program, understanding around the data, to develop a learning agenda, and then to carry out and disseminate the evaluations from this massive, ambitious program. This so far has culminated in 18 publications. We published 13 of them together in a collection that I've shown here in case you have further interest in understanding this program. So just a bit of the background. When this program was conceived, the state of Bihar was in a very difficult position, had been struggling with political upheaval, with breakdown in law and order. The health system was largely dysfunctional. But there was some hope, and there was some recent economic growth, and this was spurred in part under the leadership of a new chief minister of the state. And that chief minister actually approached Bill Gates and said, "We want to create large-scale impact for health within our state. Will you help us?" And so Bill Gates said, "Yes, we will," and funded bringing together the NGO and academic partners on this project. There also was hope in that there was new policy through the National Rural Health Mission that was focused on marginalized communities and on giving states funding and the leeway to innovate in order to address the problems that they were facing. They introduced a conditional cash transfer for facility delivery, which created a lot of movement from communities into health facilities for care. So there are some things to build on. But as you can see here in these indicators here, coverage rates of key maternal and child health indicators were very low. And over here, mortality rates, health status indicators were among the poorest in the world. But yet this project was very ambitious in setting clear targets for massive improvement within the state. This is the program area. This is the state of Bihar. The pilot, now this is a bit of a misnomer. The pilot was 28 million population, essentially the size of Texas, shown in brown. And during a 2-year period of innovation and piloting, NGOs such as CARE and several others innovated in how to reach the population with messages, information, behavior change, and services. And a lot of innovation took place. There were RCTs that were conducted. We published separately some of the results from those RCTs. And then coming out of those 2 years, went into a scale-up phase in which the NGOs pulled back their active support and provided strictly techno-managerial support to the government, with the government implementing through their own health systems. We documented 47 interventions that were being implemented across the entire continuum of care for reproductive, maternal, newborn child health, and nutrition. So this is a very complex program. Summarized it with this theory of change, where there are supply side and demand side interventions. On the supply side, there is a focus on building the capacity of the frontline workers to engage with beneficiaries, to communicate with them effectively, to provide information, behavior change communications, and link them to services. There was a massive effort to improve quality in every health facility, essentially throughout the state. There were, on the demand side, multimedia communications to raise awareness and to provide messages around healthy behaviors. There was the formation of self-help groups of women and the infusion of health messaging into these groups of women who were formed primarily around economic development and layering in health. And all of this for the purpose of increasing families, women's knowledge and healthy behaviors, leading to reductions in maternal, newborn, and infant mortality. These are the data that we had to work with, large numbers of data from a variety of partners that we brought together. I just want to highlight briefly the first two. The Mathematica evaluation was a before and a baseline and a midline. The midline taking place 2 years into implementation. So during that pilot phase, comparing 8 focus districts to the 30 non-focus districts in the state where the program was not being implemented in the first 2 years. So we were able to conduct a difference in difference before-after comparison. Then CARE had conducted a series in the second line, the community-based household surveys, which were a series of surveys initially designed to provide feedback in a monitoring mode to the program on how things were going and where course correction could be made. As time went on, CARE strengthened those surveys, and we relied upon them quite a bit as measures of change in indicators over time as the program rolled out. And both of these surveys were population representative. And as you can see in the numbers here, were really pretty sizable surveys. Vicki will be talking about the behavior change communications data sets here. We had data on self-help groups. We had data on what was going on within facilities to improve quality. Here's the evaluation design. Again, 2 years of scale up in 8 focus districts here. A rapid transition to scale up during this period right here. And then the scale up going forward across the entire state as shown here. Here are the 2 Mathematica surveys 2 years apart. Here are the community health surveys conducted by CARE running all the way through, giving us trend data. And then we have some additional communications evaluations going on. Today, we'll be presenting to you quickly an overview of what all was accomplished, what kind of changes did we see in indicators over the course of the program. We'll be looking into a couple of bright lights of the program, the self-help groups innovations and the mHealth interventions. We won't have time to go into facility quality improvement. Would love to come back and talk with you about that massive effort going on there, a lot of innovation. And then at the end, we'll be talking about some of the more forward-looking work that we're doing, trying to zero in on how to be more precise in the delivery and the evaluation of a program such as this. So our first set of results are shown here, the Mathematica survey that I've described. This is a forest plot in which we see the difference in difference, or in other words, the attributable increase in the focus districts to the program, taking the baseline and the change over time in the comparison areas into account. You can see here, and then we have it coded according to across the continuum of care, here antenatal care down to family planning. And it's color-coded according to the platform used to deliver the interventions, whether it was through the frontline workers, whether these were behaviors that were dependent upon what mothers did, or whether this was a health system function, a service function. The first point that we found, well, first of all, just in looking at this plot, you can see there's a lot of forward progress being made here. And this is attributable to the program. But 40% of indicators, when we looked at just our non-focus group, our comparison areas from baseline to the midline into 2 years into the program, 40% of indicators were showing change. So there were strong secular trends towards improvement in health. However, on top of that, the Ananya program could be seen to be responsible for improvement in 10% of indicators overall. Again, trends in most of those indicators towards improvement. So this really was a strong signal that large-scale change, again, the size of Texas over a 2-year period, it's phenomenal, the kind of change that was driven in these 8 pilot districts over a 2-year period of time, giving a lot of hope. But the other part that emerged during this period of time, that there were really important structural challenges within the health system that were holding the program back that needed to be dealt with. And CARE shifted from this focus initially on the frontline worker platform to focusing more on elements of the health system during the scale-up part of the program. And here now we see the community-based surveys conducted by CARE running all the way through the program. In this first phase, again, this is taking into account both the secular change and the change attributable to the program, but we're seeing that about 2/3 of indicators were showing improvements in this pilot phase. However, during the transition to the scale-up phase, we saw a rapid decline over a 6-month period of time or so in about 2/3 of the indicators. And in fact, in most of those that had improved in the first phase, fell back essentially to where they were before, maybe a little bit above where they were before, indicating that the system had kind of come back to the equilibrium point where it had been at the beginning of the program. And then going forward, it was a mixed bag where some of the indicators improved, some of them actually got slightly worse. And overall, over the 6 years of, or I guess 4 years of scale up that we evaluated the data on, about 20% of indicators showed a change from the very beginning of the project to the end. We went on to do an equity analysis, and Vicki Ward has presented at MCHRI on this before, so I'll just go through this very quickly. We looked at tertiles of wealth and caste status, looked at the extreme most marginalized, lowest wealth, lowest caste compared to the highest wealth, highest caste, and looked at how they had fared over the course of the program, what were the trends and indicators, and found that there were disparities at baseline that by and large favored the least marginalized, that these disparities persisted throughout the program, and in some cases they became worse, particularly for indicators that were dependent upon facility-based services. On the other hand, there were some disparities that actually got better in that they decreased and became more favorable for the poorest, the most marginalized. And these were primarily indicators that were driven by maternal behaviors and were not reliant on the health system. And so our conclusion here is that focusing on facility-based care without also addressing access and looking at what's going on in the community may improve your overall assessment of the program, but it may come at the expense of widening inequality. So you need a balanced approach to your implementation. And furthermore, it's really important to be intentional from the very beginning in your design and in your evaluations to be sure that you're addressing barriers to access and equity all the way through. Otherwise, you, again, may widen inequalities. Well, this gave us a bit of pause, and we reflected on the Sustainable Development Goals and these pledges that we as a country, that all countries of the world had made, and began to ask ourselves, how can we ensure greater equity and greater precision and predictability of the health impact of programs like this? And so the rest of our presentation is really focused on trying to answer this question. The first thing that we did was look at our self-help group work, and self-help groups of women can do many things through empowering those women, as illustrated in this quote. And just briefly, we found that actually the women who came together in self-help groups by design were more marginalized than the rest of the population. And our indicators here show it, indicators of education, literacy, wealth, for example. And when we looked at the women who were in self-help groups compared to those who were not, in the upper right, you see the proportion of indicators across these various aspects of care that were significantly improved in women in self-help groups compared to not. We then more stringently looked at those who were in self-help groups compared to who had received health layering into their group, compared them to women who were in self-help groups but had not received the self-help group health layering innovation that was developed by Project Concern International. And we also saw huge improvements in the women who received health layering into their self-help groups. So this is something that is being scaled up statewide. It's being looked at very carefully. We're now doing a systematic analysis to look at the benefits of health layering of self-help groups. So this is one of the real bright lights that addressed equity and also impact in the program. So I now will shift this over to Vicki Ward, who will talk about the communications aspects of the program.
Thanks, Gary. Okay, so we're going to drill down into our evaluation of some of the interventions of the Ananya program, and these specifically are those that were implemented by BBC Media Action. And really the goal of these interventions was on the demand side of the theory of change. So the hope was to drive the coverage, service uptake, and behavior change of these healthy behaviors. The goal was to increase behaviors associated with priority health activities that the Gates Foundation had set out at the beginning. So those activities were surrounding birth preparedness, other perinatal care activities, infant care like skin-to-skin care, exclusive breastfeeding, complementary feeding, and infection prevention practices. BBC implemented a 360-degree health messaging campaign. So on the left side, you see sort of their multimedia activities, so TV, radio, rural theater, to really drive sort of cultural uptake of these healthy behaviors. And then on the right side, you see the mobile health or mHealth job aids that were really to improve facilitation of communication between frontline workers and the women with whom they were speaking. And those are the tools that I'm going to be talking about today. So our research question in evaluating the use and the sort of benefit of these tools is, how do these tools implemented by BBC Media Action improve the health-related knowledge, attitudes, and behaviors of women in Bihar? So the first tool that I'll focus on is called Mobile Kunji, and it's a deck of color-coded cards that are stage-specific. So they're a visual demonstration tool that help frontline workers to deliver health-related education to the women with whom they were speaking. On each card was a mobile short code in which the frontline worker would call that number, and they would reach what was a recording of a Dr. Anita, who is a fictional character that delivered sort of evidence-based, lively communication about these health educational messages. In order to evaluate these tools, we use overall 5 data sets. For Mobile Kunji, we used 3 of them. The Mathematica data set, which Gary mentioned, was a true evaluation using a DID framework, and it was survey-based both at baseline prior to any implementation and midline. Unfortunately, the end line was never done, but these were huge surveys, so they were done across thousands of women. Similarly, the community-based household survey, or what we'll call CHS, was implemented by Care India throughout the longevity of the program and still going on today in what was called rounds. And so we evaluated 8 of those rounds, again, across thousands of women, and those are really cross-sectional surveys. And then BBC Media Action's own implemented survey, which was called User and Engagement, or we'll refer to as UNE. Again, a randomly selected sample, a survey-based analysis amongst 3,300 women. And the way that we look at it is that women who were surveyed were asked whether they had been exposed to the Mobile Kunji tool during their more recent frontline worker health visits. And then we compared those women who had been exposed to those who were unexposed and looked at their health-related knowledge, attitudes, and behaviors. So when we turn to sort of the timeline of implementation, similarly to what Gary presented, Mobile Kunji was launched in 2012, and then we'll look over time at what the survey sort of showed, and I'll go through that data. Turning to the results, looking at reach from the CHS survey, amongst women who reported that they had been during their most recent frontline worker visit in the past 6 months, they were asked whether they were exposed to the Mobile Kunji tool. And you see that at the peak of implementation, approximately 44% of women said that they had been exposed to the tool. Now, while that may seem sort of at first glance to be a smaller number, knowing that the population of the focal districts is 28 million, you really start to see the scale of implementation here. When we look at the data, we see that 60 million minutes of content had been accessed, and there were almost 150,000 frontline workers that were registered and using the tool. Turning to the sort of impact of these tools, when we look at, again, women who are exposed to the tool compared to women who are unexposed to the tool, and we look at their health-related behaviors, we can start to see something really interesting. This is a forest plot similar to what Gary had presented. So if the confidence interval does not cross 1, it's considered statistically significant for benefit. So you see that women who are exposed to the tool across the continuum of care more frequently performed those health-related behaviors that we're looking for, on the order of 1 to 2 times more frequently than those women who are unexposed. When we disaggregate across the Mobile Kunji, the deck of cards tool, versus Dr. Anita, just the mobile recordings or use of both, you see fairly similar results across the board. So disaggregated, you see that women who are exposed to any of those tools and throughout the period of implementation really had better health-related behaviors than those women who are unexposed. When we look at the Mathematica data, so this true evaluation using the DID framework, we can look at message recall. So women who were asked whether they remembered hearing about specific messages across the continuum of care. And you see that women who had been exposed to the tool more frequently remembered those messages than women who were unexposed, and that was across most of the messages. For recently delivered mothers, they remembered exclusive breastfeeding, complementary feeding, and hand washing messages, but most likely were not exposed to those messages about birth preparedness because it was not applicable. When we look at the health-related behaviors that were studied in the Mathematica data, we see again that there were better health-related behaviors for all women who were exposed specifically within antenatal care. So across all antenatal care messages, whether they consumed IFA tablets, whether they had performed delivery preparedness activities, and in breastfeeding, whether they had exclusively breastfed their children. You find, and that's amongst women whose children were 6 to 12 months. So really to say that women of their babies up until 6 months had exclusively breastfed. You see that women on the order of 2 to 3 times more frequently perform those activities than women who are unexposed to the tools. We don't see any major differences in immunization or contraception usage, but when we look at complementary feeding, we see that women did more commonly feed their children semi-solid or solid foods by 6 months and had better dietary diversity index for the feeding of their children. We see similar results for the UNE study. So women more commonly perform those birth preparedness activities. They more commonly exclusively breastfed their children. And in the UNE data, we also can look at whether the women then discussed those messages with others in their community, like their husband or their families or their community members. And you see that more commonly they discussed topics, and that this was really across the continuum of care, with other people in their community. You also see that they had increased trust in the frontline worker with whom they were speaking for those women who were exposed to the tool. So that's the mobile Kunji data. I'll just briefly touch on another tool that we evaluated, which was called Gupshup-Potli. And this was, we'll refer to it as GSP. This was a tool that was used by frontline workers at Village Health Day. So these were kind of health fairs that are very common across India, where women go to get immunizations for their children, health education, and health-related products. And during those times, frontline workers would provide educational messages. One of the tools that BBC created was a mobile recording that was phone access to deliver these educational messages in a lively way. And we studied whether, again, those led to significantly better knowledge, attitudes, and behaviors amongst the women who had been exposed to them. We see that this was used by 70,000 unique users. There were 3 million minutes content accessed. And again, we see that there were better results for those women who were exposed to GSP. So more commonly, they remembered those messages across the continuum of care. They more commonly had better knowledge and sometimes better behaviors when they had been exposed. So more commonly consumed IFA tablets, they had better knowledge of birth preparedness and complementary feeding activities, sort of knowing what was important to do for their babies during those stage-specific periods. They had better knowledge of vaccines and immunizations, and they more commonly used contraception.
2 minutes.
Those topics again, thank you. Again, those topics were discussed more frequently with others in their community, and we can sort of disaggregate based on whom they spoke with, but just to say that on the order, again, of 2 to 3 times, they more commonly talked about those messages with others in their community. And they more commonly had better trust in the information that was delivered. So overall, really what we see is that the use of these mHealth job aid tools led to better health-related knowledge and behaviors for those women who had been exposed to them compared to women who just had a conversation with a frontline worker without the tool. They more commonly discussed those messages with others, and they had better trust in their frontline worker. As Gary mentioned, we did do an equity sub-analysis, which we won't go into here, but just to say that really what we saw is that interventions that were related to access to care, meaning women had to go to a facility to get their health care, or that it was requiring transportation or financial resources in order to access the care, really were exposed to equity disparities. So there were disparities in the groups that were able to access those healthcare resources. Here in the mHealth tools, because the frontline worker could go to the woman or that message was delivered directly to a phone, we see a closing of those disparity gaps. And so there are important equity impacts for these mHealth messages, and that we see comparatively better impacts even for the most marginalized groups. All this data is certainly limited. These are all self-reported surveys, so they're absolutely exposed to social desirability and response biases. The CHS surveys were only collected as monitoring data rather than evaluations. There was no end-line data for the Mathematica, and we certainly can't account for clustering effects or for exposure to other interventions. But all that to say that what we see overall here is that either digital tools or mHealth tools can significantly amplify the impact from any frontline worker or healthcare provided message. We know that this can benefit disparities and access issues, and by not relying on facility-based care and being able to deliver those messages directly to women, that we can really meet the most marginalized communities where they're at. So I think overall, we know that we still have a lot more to learn about women who don't have access to a phone or don't have literacy, and really what's the impact if you don't have a frontline worker as a medium for that conversation. So those are all things that we're starting to study now and look forward to presenting them at a later date. But for now, I'll send it over to Safa, who's a wonderful member of our team. She's a public health researcher and a medical doctor by training. And she is an epidemiologist, and she's going to share on our on our geospatial analysis.
Thank you, Vicki. So yeah, I'll be presenting on this part of the evaluation, which is understanding geospatial variations in program impact. And just to clarify that for the purpose of this part of the evaluation, program impact is represented by trends over time in indicator levels or maternal child health indicator levels during the scale-up phase. So as previously mentioned, we had initially examined statewide trends over the pilot and the scale-up phase. And this is very helpful to understand the impact of the implementation intensity, which differed between the two phases. But we were conscious that there could be some heterogeneity in those trends when we go to a lower geographical level. And this could be helpful, and looking at these variations could be really helpful for understanding the local response to the program and or the program activities and its determinants of that response. So we selected 22 indicators and used data for those indicators from 4 rounds of the community-based household survey carried out in Bihar between 2014 and 2017, which covers the scale-up phase, to explore trends or to measure trends at the lowest geographical level possible for us, which was the block level. So the blocks are sub-districts. There are 38 districts in Bihar and 534 sub-districts or blocks, with each with an average population of 200,000. Because of the very small sample size at the block level, sometimes down to 20 respondents per block, for example, for each per indicator, per survey round. We had a really unstable indicator estimates with high uncertainty. And so we proceeded with, or we resorted to Bayesian modeling to smooth the estimates over states and fit space-time interaction models. And this gave us the trend at block level with 95% credible intervals, which we used to classify the direction of change for blocks. So where the 95% credible interval included the null value, we classified that block as a no change block for that specific indicator. And where it did not include the null value, it was either an increase or a decrease in trend. And so we found that for some indicators, there was a change in different directions across blocks during the scale-up phase. So some blocks experienced an increase, others experienced a decrease, others there was no change. And while for some other indicators, the change was in the same direction for all blocks, so either increasing in all blocks or decreasing in all blocks, but at different rates. This figure here summarizes all the results for the 22 indicators, and as you can see for those, there were some, most of the indicators, there was kind of variation in the direction of change. And so for those indicators, our next question was, why is this happening? What is it? Are there any contextual or program-related factors that is determining the direction of change? So we proceeded with investigating factors associated with block level trends, or the direction of change specifically, starting with a really wide, complex conceptual model for all that we could hypothesize could be happening, a lot of contextual factors, such as geographical factors, as well as program-related factors that could be interacting with each other and or independently driving the outcome, driving the change over time, so acting as facilitators or barriers. We explored data availability at block level and ended up trimming the conceptual model that we had based on the data availability. We were able to get data on block level data on geographical factors such as remoteness from populous towns, forest coverage, road network, power availability. We also had data on health facility readiness for maternal and child health services. And all these data were before or around the beginning of the scale-up phase. We also had data on changes during the scale-up phase, for example, frontline worker visits, substantial frontline workers, membership of self-help groups, and wealth. And so we operationalized the conceptual model with multi-level logistic regression using the outcome, with the outcome as whether the indicator level increased over time or not in each block for each indicator, and all the other data used as independent variables, with adjusting as well for the baseline level, for the level of the indicator at the beginning of the scale-up phase. And we also tested the interactions in order to operationalize the conceptual model. We found some interesting signals. This is still work in progress, but I think there's some interesting signals emerging. For example, we find that for birth preparedness, for example, one of the important factors is a program-related factor, which is frontline changes in frontline worker visits or trends in frontline worker visits. We also found that, for example, dry cord care, the trend in dry cord care was influenced by facility readiness for maternal child health services. And for frontline worker visits themselves, we found that an important conceptual factor was night lighting, for example. And for all outcomes, the baseline value was always important. The higher the baseline value, the lower the likelihood or the lower the odds of further increase. So this is really a work in progress. We hope to continue to learn more. But the really important signals are emerging around what could be some barriers and facilitators for progress. So that's all. Thank you for listening. And next, we will be hearing from Carmen. So Carmen is a postdoctoral research fellow from the University of Agder in Norway, and she holds a master's and PhD in system dynamics. And she will be presenting the application of system dynamics modeling to understand the needs of different subgroups for programmatic intervention. And so over to you, Carmen.
Thank you, Safa. Hi, everyone. Today we will be presenting our ongoing system dynamics modeling project to identify the needs of mothers with higher parities to promote institutional delivery in West Champaran, Bihar, India. West Champaran is one of the 38 districts in Bihar and is also one of the focal districts. One of our main research questions is to understand the causes of the inconsistency in institutional delivery rate of marginalized women with different parities in West Champaran between 2012 and 2019, despite multiple interventions in the health systems. And one of the sub-questions is, what are the leverage points in the system for increasing institutional delivery, especially for higher parity women? This graph is what we normally call a reference mode in system dynamics field. It is a behavior over time graph to which the model output to compare. And then these four lines shows the institutional delivery rate of women with different parities. It seems that the green line, which is the women with one child, the likelihood of delivering in institution is higher than the rest of the groups, which is women with 2 children in the yellow with the yellow line, and the light orange line shows the trend of the women with 3 children, and the dark red is the trend for the women with 4 and above children. System dynamics is a methodology useful in studying the behavior in complex systems and to understand the underlying causes of the behaviors. A complex system is defined as an environment where actors interrelate to generate certain behaviors over time. And some of the characteristics of a complex system is the accumulation, which causes delays, circular causality, non-linearity. And the main tools that we use in system dynamics modeling are causal loop diagrams and stock and flow diagrams. I'll share with you some snapshots of these two kind of tools later on. System dynamic modeling was founded by the late Professor J. Forrester of MIT. This methodology was originated from control theory and servo mechanism. Forrester and his mentor, Gordon Brown, developed feedback control systems for the control of radar antennas and gun mounts to direct fighter jets against enemy targets during World War II. After that, he brought his knowledge from electrical engineering to the Sloan School of Management in MIT in 1956, and thus creating system dynamics. From year 2000 to year 2019, system dynamics has been applied in various areas of the health system. For example, the aging and population, communicable and non-communicable diseases, healthcare process and policies, neonatology, obstetrics or gynecology, or supply and demand in healthcare or healthcare systems, or even human body and behavior, medical treatment. So especially after 2013, the publication in using ST in healthcare system has increased considerably. These are the 2 snapshots of causal loop diagram and stock and flow diagram. Causal loop diagrams are useful in presenting major causal relationships that gives rise to the problematic behavior. And it is also used to explain dominance and shifting dominance between these causal loops. Whereas stock and flow diagram is the actual quantitative model. It consists of stocks, flows, variables, constants, and formulas. Stocks and constants hold values, while flows and variables contain formulas. And stock can only be changed through flows. That means that stocks can only be changed through these equations. The advantages of using simulation in research includes the improving of understanding of our understanding of the complex system and dynamics within the systems. And we can use simulation to project what would happen should the structure of the system remain unchanged. And we can also use the simulation to conduct various scenario analysis in order to find the best scenarios that we would like to achieve. Or we can use simulation as a tool to improve human judgment, strategy development, policy or program design, and or decision making. In the R System Dynamics modeling project, we synthesize and integrate quantitative and qualitative data because we're trying to construct the part of the system that gives rise to the problematic behavior. So we need a lot of evidence. Some of the quantitative data that we use are publicly accessible, such as the sensor data and the health management information data. And some of the quantitative data are curated in Stanford and in Cairn, India. We also look up qualitative data that such as published papers, government reports, and policy briefs. At the broadest level, ST modeling can be divided into 4 stages. The whole process is highly iterative, especially from the conceptualization to the formulation and testing. Only until we have gained enough understanding and confidence in the model will we move on to policies assessment and to design new policy or programs to improve the system behavior. Now we're going to take a look at our modeling process, where we stand right now, and also how we started the project. Initially, we rely on expert advice and data analysis to start the project. Group model building is also a good tool to be used to initiate a project, because when when we gather the experts in the same group and invite them to provide their view on the system, then we can gather different perspective of the views from different actors from different part of the system, and then create the concept model version 1. The concept model V1, I call it V1 here. It's a model that consists of flaw and limited understanding. And from there, we use it as a discussion tool to initiate discussion with stakeholders and with experts to elicit their view, and also to invite criticism, and also to invite challenge to our assumptions. So through that, we improve our assumptions. Through the improvement of assumptions, we increase our understanding. Then we move on to develop the full model. Even for the full model, we have developed a couple of 2 versions, because the first version was not, we felt it was not, we developed the second version because we have refined the research questions. So right now we are in the stage of iterating between the full model and the concept model version 2. The version 2, it's developed based on the dynamics that we have found from the full model. So concept model V2 can be used to discuss with stakeholders in the preliminary presentation, or with audience who are non-technical. The System Dynamics project is in a unique position because there has been a large collection of data sets and published work available on maternal healthcare in Bihar. And we rely on this previous work to guide our modeling effort. Through the model building process, the team also examines the assumptions and form potential research questions. The result of these potential research questions can be used to update the model. So far, we have 5 sub-models within the full models. Each of these sub-models are considered as subsystems. Currently, we are still in the progress of building the model. We are populating the model with data, calibrating and testing vigorously, and also trying to replicate the reference mode, which is to test the ability of the model in capturing the problematic the structure that gives rise to the problematic behavior. So some of the submodels are the birth orders, institutional delivery rate, the medical professional capacity and perceived quality of care, ASHA's capacity, and the strength between the belief in institutional and home delivery.
2 minutes, Carmen.
Okay, thanks. So the causal loop diagram consists of 5 major, the concept model V2 consists of 5 major causal loops. These are the 5 causal loops. And it also, the stock and flow diagram, which is a quantitative model of the version 2 concept model, consists of 5 major sectors. These 5 major sectors are the simplified structures from the 5 sub-models from the full model. This graph shows the example of how we use the model to test intervention points. We test 6 points, and the 0 is the baseline, which is the dark blue line. At this stage, it shows that decreasing the childcare costs seems to be most effective, which is represented by this purple line from test 5, followed by decreasing the inflow of pregnant women, which is the dotted green line from test 7, and then decreasing the ASHA capacities adjustment time seems to help the dark green line. And the fourth potential intervention point is to change the way the women perceive safety associated with institutional delivery. For example, lengthening the horizon of the reference points. If the women base their decision on their past or most recent birth outcomes in order to make the decision for the next delivery location, then it may vary. But if they are able to understand that in the long term, when they look at the trend, the mortality for infant and maternal and infant mortality associated with institutional delivery is decreasing, then they encourage the women to adhere to institutional delivery for their subsequent pregnancies. So the implication for the programmatic interventions, if these yellow dots represent the subgroups, then we can develop different types of programs to intervene, to address to the needs of these different subgroups instead of one-size-fits-all program. And through the model, we can test the system-wide impact of these different programs before it is actually implemented in the population at the population level. The potential research for this project can be broadening the model boundary to study another complex problem, or to trace the characteristics of target population with various social determinants of health or health conditions to further understand how that affects their decision for birthing location. Or maybe we can also customize the model to study a similar problem in another location, for example, another district or another country. So that's all for my presentation. Thank you.
So Tony,
that was amazing.
Just
yeah.
Back over to you now, and just to say that we've tried to illustrate the way in which we approach evaluating such a large-scale program and what we're learning about trying to be more precise in the way these programs are designed and implemented.
And that was an amazing group of both technology as well as the size and scope that you're trying to attempt, which is just an amazing presentation. I wanted to get the first question to Tanmay MCHRI, who's basically the care director in Bihar, and sort of get his opinion about what he thinks would be the sort of learning from this program that on the ground. Tanmay?
Tanmay is joining us from a train in India. He might be having some bandwidth. Oh, here he comes.
There it goes.
Very great.
Can you hear us, Tanmay?
Yeah. Just for the back. Yeah, I can hear you. Can you hear me?
Yes.
Yes.
Yeah. Sorry for the bandwidth issue. The overall learning from the Ananya pilot and its scale-up was that human behavior don't change that often, and it's a complex program which takes care of everything on ground. While dealing with such a complex program and working closely with government, sustainability needs to be built into the system so that whatever is being actually implemented, that can be taken forward by the system itself. A donor-funded, third-party supported program can only do a bit, but ultimately building the whole thing into the system is the main important aspect. And regarding data needs to be granular. Sharing needs to be as a pack. And as granular data available, we can have questioning of the micro assumption behind the micro theories of change, building into the overall theory of change. So having data playing that role through a of the hour. Overall, yes, the program gave us that learning.
What's interesting is that, thank you so much for joining us. I was from a train in Bihar, so I think that's pretty amazing technology as it is right there. And also, it seems like the learnings from Bihar and this large project can be applied here as well. The same problems are operative here. One of the big questions really is, what from the self-help group memberships and the health layering, how do we use technology as Vicky described to basically help with the health layering in these self-help groups? Any ideas from the group?
I missed a part of your, was that for me?
Go ahead, Tanmay. Yes, it was for anyone, please.
Yeah, actually, technology was an inbuilt plan in the whole self-help group system, and starting from Anita's voice, mobile Kunji, as well as Gapsap Putli, the objective was to ensure that with the passage of time, as more people start using this kind of smartphones and all other stuff, we can have a continued process of cascade reaction, reaching more and more platforms as fast as possible. Over to Gary.
Yeah, it's a great question, and I would just like to emphasize the importance of bringing technologies into the context and into the culture in a way that is appropriate, that is desired, that's taken up, and that's used ultimately. And So as Tanmay has said, there's a lot of effort around the self-help groups to bring technology in appropriate ways. Vicky may want to add more.
Just to add that I think we see the benefit of having a trusted source from within one's own community who delivers the message as associated with amplified impact, which I think is important for us to know both as physicians or sort of physician delivering information, that can be an important adjunct to how we deliver information here, both to patients with whom we're speaking. We saw that within frontline worker visits, but also if we are associated with sort of the COVID pandemic, if we're delivering information at a distance, that using those technology tools to help deliver information can really benefit our patients in a unique way.
What I'm hearing you saying is that the technology itself is not as helpful as the technology delivered as an adjunct with a trusted source like a healthcare frontline healthcare delivery worker. Is that right?
Well, we don't know yet. I think that's some of the work that we're trying to look at now. If you just deliver the information without somebody sort of as a mode of the communication, how much benefit do you see? And that's something we're studying now. But we do know that delivery of information through the trusted source, even if it's digital or sort of recorded, that we do see health benefit associated with it.
Tony, I would like to add that that part of the question regarding only technology or technology as a job aid, actually from our other innovation regarding the use of the technology as a continuum of care service, evolving into CAS, a common application software used by the frontline workers, it did really show a multiplicative effect.
Yeah, I think that's right. I just wanted to add in one more question, was what was the propensity of women to join the self-help groups? Were there cultural issues, and would technology help them form the self-help groups? Because it seems like they had to be in the self-help groups first before they got the healthcare benefit.
Well, it's an interesting question. I mean, we're finding that the women who join self-help groups tend to be a little bit older. We did some sub-analyses and found that the groups were less effective for younger women, particularly for adolescent age women. And so we're trying to learn how to attract them into groups. And it may in part be technology that attracts them to come into groups. So that the way in which the communications and the interactions among the group members are carried out may be more, technically powered and more attractive to those younger women. So they really do go hand in hand.
And then one last question on the question and answer was from the frontline worker side. What do you think the morale or the benefit for them is with the technology interface and with having these help aids? Has that made them feel more powerful, more safe, more sure? Do you think it had an effect at all? What are your thoughts?
Yeah, so BBC Media Action did quite a bit of study, both amongst they surveyed frontline workers who had used the tools. And by and large, you see that women had better frontline workers had better self-efficacy. They sort of felt better about their jobs and they felt like they could be more effective. And on the other side, we saw that the beneficiaries trusted their frontline worker more. They had longer interactions and they sort of trusted the information that was being provided. So on both sides, you see benefit for using these technology tools.
That's amazing. We have about a minute left. And so I just wanted, this is the question I always ask at the end of these seminars, which is, what are the rate limiting steps for achieving these goals of equity in this challenging global situation? And where would either philanthropy or some sort of investment accelerate, and where would you put it?
One thing that CARE invested a great deal in were tools to put in the frontline workers' hands that enabled them to scan the entire population. They were sure that they captured every household and that systems were set up to hold them to account, essentially, for reaching everyone as a way to try to overcome that equity issue. So there's another example of how technology could be helpful. But one of our main learnings was you have to be intentional about it going in. That part of, this program was aimed at a population level, but it turned out that it didn't entirely achieve that, despite the best of intentions. And it wasn't until, you know, the measurement and the data started to come out showing, you know, the inequities that really started to be able to bore in and be more precise in how to reach them. And CARE Tanmay may want to answer as well, is doing a great deal to try to be more precise about that.
The rate limiting step maybe rate limiting steps are all around the accessibility. And as Gary mentioned, that making these tools accessible and making the information available to people and building a trust between different cadres. These were different rate limiting steps, and these were around which the program was interwoven, and the overall journey tells the story of interplay between these.
Wow, that's quite profound and quite universal as well. And so I think, thank you very much, Tanmay, and Carmen and Safa and Vicky and Gary, thank you very much for joining us. I would ask any of the MCHRI community that think they can actually have an impact on any of the issues that we talked about today, please get a hold of this very talented group. I think from all the technology we have to develop, the tools, innovations, we should be able to make an impact with this amazing group on the ground. And so thank you for the presentation today, and hopefully we'll see a follow-up where the equities, technologies, and healthcare will be actually improved in the future. So thank you very much for joining us.
Thank you. Thank you all very much.
Thank you.
Appreciate it.